This is a video presentation of hysteroscopic myoma resection for deep intracavitary and intramural myomas. As per the new AAGL classification, myomas are classified from type 0 to type 7. While resection of type 0 and 1 myomas is easy, resecting type 2, 3 and 4 myomas is difficult as there is risk of perforation. If we understand the forces acting upon a fibroid, it becomes clear that the position of a submucous myoma is determined by the stronger of two opposing forces: the myometrium behind the fibroid trying to push it into the cavity, and the myometrial capsule between the fibroid and the cavity holding it back. If these restraining fibers are incised, the myoma automatically starts projecting into the cavity due to the force of the myometrium. This is demonstrated by a technique called Hamu's massage. Reduction of the inflow pressure of the distending medium results in the fibroid bulging into the uterine cavity. This is a patient with a type 2 submucous myoma, partly projecting into the uterine cavity and partly located within the uterine wall. A cursory examination of the rest of the uterine cavity shows that the uterine cavity is normal with no other apparent pathology. Resection is started and resection is easily carried out up till the level of the endometrium, up till the level of the endometrial lining. However, at the level where the fibroid is flush to the endometrial lining, the surgeon is faced with the dilemma of either cutting into the myometrium to scrape out the fibroid, thereby risking a perforation, versus leaving a part of the fibroid behind. At this stage, the hysteroscope is removed and a vigorous bimanual massage is given, causing the myometrium to contract and push the fibroid into the cavity. After uterine massage, when the hysteroscope is reinserted, the fibroid has shifted slightly towards the cavity, making it more amenable for resection. This process can be repeated 2 or 3 times until the entire mass of the fibroid has been removed. This is a patient with a type 3 posterior wall submucous fibroid. The fibroid is only slightly jutting or touching the endometrial cavity, but most of the fibroid is still within the uterine wall. It is only after the first primary cut has been made that the fibroid is seen. Notice the difference in color and texture between the myoma and the surrounding normal myometrium. Resection is continued, taking 2 or 3 successive cuts until the fibroid is flush to the level of the endometrial lining, or even a little deeper, till the surgeon feels comfortable to continue the resection. However, after the first 2 or 3 cuts have been made, the surgeon reaches a point where he has to either dissect beyond the normal endometrial lining or stop the resection there, thereby leaving a part of the fibroid still attached to the uterus. It is at this stage that the surgeon dissects between the fibroid capsule and the normal myometrium using a cold loop, that is only mechanical force, only activating the electrode in short bursts of current to detach the myoma from its attachment to the myometrium. Using this technique, the myoma is gradually peeled off from its attachment to the normal myometrium. Using this technique, the risk of perforation is minimized, and also the risk of thermal damage to the surrounding endometrium is minimal. Here, the fibroid is seen to be completely detached from its base. This is a patient with a type 4 myoma, completely intramural and not indenting the endometrium. A good mapping of the fibroid by ultrasound clearly elicits the depth of the fibroid in the endometrium as well as the safety margin available up to serosa. It is only after the first 1 or 2 cuts on the endometrium that the fibroid starts becoming visible as a diffuse elevation over the anterior wall. Following the same principle as discussed earlier, rather than dissecting into the myometrium using a burrowing technique and increasing the risk of perforation, the extent of the fibroid is first carefully determined by the operating surgeon. Next, using a cold loop dissection technique, an attempt is made to push the fibroid away from its attachment to the normal myometrium. This displacement is sometimes anteriorly and sometimes posteriorly towards the surgeon in a gradual effort to shift the fibroid away from its normal attachment and into the endometrial cavity. Using mechanical, the fibroid is pushed away from its attachment to the myometrium, and gradually the fibroid is seen to shift closer to the endometrial cavity, moving away from its attachment to the normal myometrium. This displacement is accompanied by short bursts of energy in order to release the fibroid from the fibers over the circumference of the fibroid that are holding it back. By this gradual pushing and pulling, the fibroid is gradually seen to shift closer to the cavity from its original intramural location. The process is meticulously continued slowly and steadily till the fibroid can be gradually lifted away from its attachment, thereby effectively converting a more advanced or a more deep intramural type of fibroid into a more submucous one. As we can see here, the fibroid is slowly but surely getting displaced towards the endometrial cavity until such a point that the cold loop of the resectoscope is able to lift the fibroid away from its attachment, thereby exposing the normal pink myometrium behind the fibroid. Effectively, a type 4 fibroid has been converted into a type 1 fibroid, completely eliminating the need for burrowing into the uterine cavity and thereby increasing the risk of perforation. After a majority of the chunk of the fibroid has been removed, the process is slowly continued, removing the remaining bits of the fibroid gradually away from its attachment to the normal myometrium. It is very important to not forget the basic principles of resection and to activate the electrode only while resecting away from the fundus, except when very short bursts of energy are used in order to detach the fibroid from its attachment to the capsule and from its attachment to the normal myometrium. As we can see here, the remnant pieces of the fibroid are slowly getting detached from their attachment to the uterine myometrium. In conclusion, cold loop dissection and Hamu's uterine massage are extremely useful techniques for converting a deep intramural myoma into a submucous one. This technique minimizes the risk of perforation and yet ensures that very little or no remnant of the fibroid is left behind, thereby ensuring a complete surgery. Using a combination of these techniques, the surgeon can convert a deep intramural myoma into a submucous myoma, thereby making resection easier, safer, and quicker. The myoma has now been completely excised. Thank you so much for your patience.